should we discontinue her Seroquel?
Something have to change because she just falling. I know
I
she's
mean, I haven't
supposed to
changed
sleep.
her medication. We haven't changed her
See,
medication.
she'll be here. But if she speak, she can't hear me. Can you hear me? No, she can't.
She says yes.
Oh, she yes? Can you say something?
Good afternoon.
No.
See, I think she said good afternoon. So let me see if I turn up the volume, if I'll be able to hear. Where the foolish volume is now.
Do you want me to say it
Oh.
again?
Where is the volume now, Norma?
Volume are usually on that side.
That's it, but it's not there. I don't.
It's not right here.
It won't be over. All right, let me see.
Activating, just try once. Okay, that's 100%.
Yeah. But I'm still not hearing anything. Hello? Can you say something again?
Sure.
See,
Can you hear me now?
Sure, but it's so low.
No, it's coming from somewhere.
Wonder if it is from my speaker around here
Yeah.
that's messing me up. Norma, come help.
I think it's the speaker.
All right, this I turn this up. Can you say something again?
Sure.
Good, thank you. You're in for this meeting at 1 o'clock?
Yes, I'm teaching the class.
Okay, so I'm extra early. I'm trying to work.
It's early is always better.
Yes, because I'm trying to get my speaker up because I couldn't hear anyone.
Yes.
So that's why I'm using you as.
Don't worry about it.
Thank you. I'll just stay on because I don't want to lose it.
All right.
All right, no problem. So instead of watching her, I will just put it on here.
Hi, Dr. Phoenix. How are you?
Fine. How are you, Michelle?
I'm fine, thank you. You all set?
Yeah, I think so. Thanks for sending the chart. I'm sorry I overlooked it yesterday.
That's okay. No worries. That's fine.
Will it be okay if I introduce you, Michelle?
Oh yeah, of course. I'll just keep my camera off, as you said, and I'll just observe as you said, and make notes, and just quietly observe. If anyone has any questions.
You don't have to keep your camera off. I thought you might prefer that.
Oh, okay. I'll turn it on. Let me just go do my hair and then I'll turn it on. I'll be right back.
I can't even spell. Oh Lord Jesus, help me.
Good afternoon. Is this the virtual for the sepsis training?
Yes, it is.
Oh, okay. I just want to be sure. Thank you.
You're welcome.
Hello? Yes. Yes, and that is for 422. The tax on insurance is 420 something. I have the figures. 420. Let me get it. In some something here. Hold on. I wrote it down. So subtract from that will be 422, 424.74. So the tax is 339. Insurance.
Ouch.
The tax is 339.99, and the insurance $84.75. Yes, that's the mortgage insurance. It is 5.75.
Good afternoon, everyone. It is 1 o'clock. Thank you for taking the time to attend the sepsis training. I know some people are still joining in, and we'll have more people join in, but we also want to be respectful of everyone's time so we can go ahead and get started. My name is Tammy Oshie. I'm the Quality Improvement Manager with Nexus. Some of you know me, some of you have seen multiple emails from me. Thank you for taking the time this afternoon. I am going to hand it over to Dr. Phoenix as she will get started with this training. If you have any questions, please put it in the chat. And all the activities that we will be doing, Dr. Phoenix will be talking to us how we'll be getting through. But if you have any questions, put it into the chat, and I would randomly interrupt when I see questions in between and ask Dr. Phoenix the questions, unless you wanted to wait till a certain period to take questions.
So I am going to set aside time at the end, but if there's a burning question, I'm happy to try to respond to it during the presentation. And is someone else going to put the poll up? Because we were going to start with a poll.
Yes, yes. Once you are ready for the poll, just let us know. Pam will put the poll up, and then once it's ready for the breakout, just let us know, and then we'll do the breakout as well. And
Okay.
myself and Pam on here, if you need us, we'll just call out our names. We're here.
Okay, wonderful. Thank you so much.
All right.
So I guess I'll go ahead and introduce the day, and then we'll start off with the poll, and then I'll jump in. So I'm Dr. Janet Phoenix. I'm a senior consultant with the Grant Group. I'm very happy to be here with you this afternoon. And thanks so much to the Primary Care Coalition for asking us to put this training together. I think there's broad recognition that sepsis can be a serious condition, and we want to assist in whatever way we can to help with recognizing sepsis early. This training will be the first of two. The second one will take place a week from today. And you should also know that as we were putting together the materials, gathering information for the training, we've also been preparing a Train the Trainer manual that we expect will be available to you in May. And so hopefully with the combination of this PowerPoint, the training that you've been through, and the manual, you'll be able to train others at your institutions about preventive measures for sepsis and also early recognition. With that, I think we'll get started with the poll, and then I'll jump in and outline the day.
Sorry, Dr. Phoenix, one quick thing. Sorry, housekeeping. I'm gonna go through the attendance list and sort of mark through the list that I have to know who is here and from what SNF. I don't see any, I see one phone number, so I might send that person a chat just so you know exactly who you are, but I'll try to use that to take attendance. And another thing, please let's keep our mind on mute just for background noise. Over to you, Dr. Phoenix.
Yes, I think we're ready for the poll. So let's give it maybe another minute to give people an opportunity to respond, and then we'll take a look at the results. Okay, so are we able to see the results of the poll? Okay, that's great news. It looks like there's about
Where is the
two.
poll? I can't see the poll. I'm not seeing the poll.
Are you using a phone to connect to the webinar?
Yes, I'm using my phone.
Yeah, and I think it may be that the interaction with the app and your phone may not permit you to respond to the poll.
I can't even see it.
Yes, I think there just may be an issue in terms of the interface. But the poll questions, I'll read them for you. The first one was, do you use the stop and watch tool for the identification of sepsis? 64% of people said yes, 36% of people said no. The second question was, are you familiar with Interact as a tool for the identification of sepsis? 72% said yes, and 28% said no. And then the last question was, are there other tools that you are using to assist with early identification of sepsis? 48% said yes, and 52% said no. So that's our poll. And I asked that poll question at the outset because I wanted to get a sense of whether and how people who are part of the training session today are using some of the tools that are out there to assist in the process. And so I'm really pleased with the results, and we're going to be spending a little more time gaining some familiarity and making some comparisons about the tools later in the training. So let me get started and just give you an idea of what we're going to cover today. So this is the outline of today's training. So we're going to start off really defining sepsis and talking a little bit about how the definition has changed over time. Then we'll talk about how sepsis affects the body, the things that are going on inside the body that make the symptoms that we see on the outside, the confusion, the hypotension, the rapid heart rate, the rapid respiratory rate. We'll talk a little bit about the things in the body that are causing that to happen. And then we're going to do a small group exercise where we'll put you into small groups with 8 to 10 of your colleagues and walk you through a case study and let you kind of talk about what you might do if that resident were experiencing those symptoms in your facility. And then we'll come back and talk about it. And then we'll talk about the data, just the extent of the problem in the United States, the extent of the problem in Maryland, and we have a little bit of data on Montgomery County. And then we'll finish out the day really talking about strategies, barriers, and facilitators to your improving your ability to recognize sepsis early in the long-term care setting. And then we'll talk about some programs that have been implemented in other parts of the country where they've actually been able to successfully manage sepsis when they've recognized it early and have cut down on the number of residents who've had to be transferred to acute care facilities. And that'll be it for day one. So the sepsis is defined as a life-threatening organ dysfunction, which is really caused by the immune system, the host's response to infection that goes out of control, if you will. So it's the body's reaction to an infection, but it's an extreme reaction. And it can happen when a current infection kind of triggers a chain reaction through your body that can have deadly results, often resulting in something called a cytokine storm, which you may have heard about in the context of COVID-19. So it all starts with an infection. And the goal, I think everyone's goal, is to really prevent infections when possible. But if they can't be prevented, to recognize them early enough that we can interrupt this pathway that leads to sepsis. So sepsis isn't a medical emergency, it's life-threatening, and without timely treatment, it can lead to organ failure and death, and that's what we refer to as septic shock. So these are common infections, and many of the people who are coming to your facilities for skilled nursing care, or who may be living in the long-term care setting, have these common infections: pneumonia, urinary tract infections, gastrointestinal infections, soft tissue infections. And these are the infections.
Sorry, Dr. Phoenix, are you supposed to be sharing your slides, or is that something you wanted me to do? I thought you were going to be sharing your slides.
I see the slides.
I don't see it. Does anyone else see the slides? Or maybe it's just on my end?
No, we cannot see the
We
slide.
cannot see.
No, no.
Okay. So maybe you might want to stop sharing and share it again. And if it doesn't work, let me know and I'll try to share it on my end.
Okay. Can you see them now?
Yes.
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 Okay, so sorry about that. I'm not sure what happened. And so now I'm thinking, if I go to the slideshow, I'm wondering if it will disappear again.
Well, let's see. Let's try it.
I'm going to try it. So can you see the presentation?
Yes, we can.
You should be seeing the cover page. Okay,
Yeah.
Yep.
great. So sorry about that. Okay, so so these infections are have been reported by the Centers for Disease Control and Prevention as being the ones that most commonly lead to sepsis. And then these organisms, Staphylococcus, E. coli, and Streptococcus, are the organisms, the infectious organisms that most often cause sepsis. Now, who's at risk? Obviously, anyone can get an infection, and that infection could progress if it's not recognized early to sepsis. But there are some people who are more at risk than others. So people with chronic medical conditions, so especially people who have some kind of immunocompromise, like people with HIV or with cancer. But there are a number of other chronic conditions as well that can make it more likely that the infection will progress. Older age is associated with sepsis, and as well as having been a sepsis survivor or having been recently hospitalized. So these are all factors that seem to be important. And one thing that you may want to think about when people come to your facility and they have one or more of these conditions is that, that you somehow flag those individuals so that if they develop an infection, you can monitor them more closely, recognize the infection earlier, because they are at greater risk for their infection becoming out of control and leading to sepsis. Cancer seems to be a predictive factor all on its own, independent of many of the other risk factors. So it's a predictive factor for death and sepsis. It's noteworthy. Many cancer patients have compromised immune systems, and we think this is the factor that's really causing them to be at greater risk for death if they develop sepsis. The immunocompromise, of course, makes it harder for them to resist an infection and makes it more likely that the infection will become full-blown. Diabetes is also a risk factor. And it functions in much the same way that cancer does in terms of leading to some kind of an immune dysfunction. It makes it harder for the body to clear bacteria, especially. And the long-term sepsis mortality when diabetes is thrown into the mix is 60 to 80%. So basically what we're saying is that chronic disease is a risk factor. And because of the reduction in the function of immune cells, because of the inability, the lesser ability of the body to clear bacteria, it increases the complication rate and increases the possibility of mortality. Now, I mentioned older age, and we think really the reason why older people are may become more debilitated, may be more likely for their infections to become sepsis is because of this gradual decline that can take place in the immune system over time as we get older. So older age in and of itself is an additional risk factor. But one of the biggest risk factors is actually having had sepsis before. And this is, again, something that you should think about and consider when people come to your facility, especially if they've been discharged from hospital after having had an episode of sepsis. They really are at greater risk. They are also more likely to have some long-term results from that sepsis episode, the first sepsis episode. So they're more likely to have cognitive dysfunction. They're more likely to go back to the hospital, either for that infection or for another one that they might develop. So they really need to be watched a bit more closely, the people who've had sepsis before. So when someone comes to your facility, it would be very helpful to kind of ask these questions. Has the resident had sepsis previously? Do they have an active infection of some kind? Do they have a malignancy? And if the answer is yes to one or more of these questions, you may want to consider a way, either using the electronic health record or some other mechanism, to identify these residents as being at higher risk for sepsis. Now I'm going to talk a little bit about the immune system, because really the immune system is at the heart of sepsis, and it's this uncontrolled reaction of the body to infection that really defines sepsis. So, I want to talk a bit about kind of where infections start and what happens in the normal immune response to infection. So if you get a scrape or a cut or a fall or a bruise, then, you get some local swelling and redness that happens at the site of that cut or that bruise. And this is the way the immune system is supposed to function. And the swelling takes place because you have cells, infection-fighting cells that live in the skin that are being mobilized to try to make sure that, that no infection spreads from that site where the cut or the bruise is to other parts of the body. So those cells come in, but in the process of fighting the, the cut or the scrape or any germs that may have been introduced into your body at that site, they can also damage local tissue. So it's, there's a yin and a yang to this. The good things that the infection fighting cells do by fighting the bacteria or the virus or anything else that might be entering the body at the site of that cut also damages the local tissue. And then the redness and the swelling also occurs because you get cells coming from other parts of the body that are traveling through the blood vessels to get there to assist with this fight. So some are local in the skin, and then some are traveling through the blood system to get there to help fight whatever is going on at the site of the cut or the bruise or the scrape, but the place where the infectious particles might be entering your body. So that local tissue damage happens when you get these chemicals that are released by the infection-fighting cells, and they have a lot of different names, these cells. We're going to see a video in a few minutes, and they'll be talking about things like macrophages and neutrophils, and a lot of different, multisyllabic names for these infection-fighting cells, but they're all really trying to accomplish the same objective, which is to keep you safe and to kill anything that might be entering your body that could harm you. And so some things are, mobilized quickly, and that's kind of a general defense system. It's not specific. And then some things take a time for them to ramp up, particularly those things that are coming in through the blood vessels that travel through the blood. Things like antibodies, for example, they take time to prepare. It can take 2 or 3 days for those to ramp up, and they tend to be very specifically focused on a single kind of bug. But all of this happens, again, locally. You get the circulation ramps up, the cells are being mobilized from other parts of the body, and the blood vessels themselves open up so that they can bring more fluid to the area to help flush out the infection, to help bring more of those infection-fighting cells in to help combat the infection. And then the very last process that takes place in these small blood cells is a clotting process. And you might think, well, clots, that's not good. But in this circumstance, it's really, again, it's part of the body's defense system to try to wall off the infection. So if it forms a clot in the small blood vessel, then that blocks off the ability of those infectious particles to travel through the blood to other parts of the body. So it's actually a good thing. But like all good things, too much is too much. So what can happen is if you get this clotting process taking place in a lot of different places. So let's say the infection breaks loose and you have infectious particles in many different parts of your body and in major organs that you need, like your heart and your kidney, then you get this overwhelming clotting process going on. You get this overwhelming manufacture of infection-fighting cells. The chemicals that they're releasing to try to kill the bugs are killing your tissues in lots of different places. So if this happens in a vital organ or in several vital organs at the same time, then this is what we call sepsis. So this is a very complicated looking diagram, but really it's just intended to show you local infection on the left-hand side, okay? And to show you what's happening at the cellular level where these infection-fighting chemicals are being released into the local area where the cut or the bruise may be. Local is good, okay? But what can happen when you get to the middle column there is if this is happening in a lot of major organs in the body, the brain, the liver, then you can have that damage occurring in something that has to be healthy if you're going to survive. And then on the right-hand side, you'll see that you're beginning to see damage to critical organ systems. And the leaking of these infection-fighting chemicals and cells into local tissue that may be in your heart or in your kidney or in your lungs. And this is why we see the symptoms. You see multi-organ dysfunction. It's an infection that has run rampant, and your body's ability to fight it has also run rampant, and it's damaging critical systems at the same time that it's trying to fight this infection that's happening all over the body. But it all starts with the blood vessels. It all starts with the skin around the site of the infection, and then it spreads. So septic shock is what we describe when you get these small clots forming all over the body, and then you get a slowing of blood flow. So, hypotension is one thing that septic patients exhibit. So the blood pressure goes down. Okay, and the reason the blood pressure is going down is because all of this fluid is leaking out of the blood vessels and into the surrounding tissue. And so there isn't enough to provide, needed oxygen to your heart, to your kidney, to your lungs. And so your tissues are actually starving for oxygen because they're not getting the oxygen circulating in the same way that they would normally with the blood flow, because the blood flow is cutting off. The clotting process and the slowing process is cutting off the blood supply to the organs, and it's cutting off the oxygen that the organs need to function properly. Pneumonia is probably the most common organ system affected, but any organ system and many organ systems are affected during sepsis. But we are now beginning to understand that in the end stage of COVID-19 is really very, very similar to what we see in the end stages of sepsis. It's a multi-organ breakdown. In this case, it's a viral organism that's causing the problem. You have virus, in many, many parts of the body, and the body is trying to fight that off. And in the process, it's damaging healthy, normal tissue. So early recognition of sepsis symptoms is important in recognizing the people who go on to develop more serious COVID-19 infection. This happens in 2 to 5% of people who get COVID-19. And so the tissue damage is really the problem, and this is happening at the microcellular level in many, many tissues are in the body. So now we have a video that was put together by the Minnesota Hospital Association, and they're going to kind of walk you through some of the signs and symptoms and go over some of these concepts about how sepsis really damages the body.
So Dr. Phoenix, we can't hear it.
Okay. Can you hear anything?
No, not related to the video, no. I think you might have to go to like share your audio. I believe there's a part where you can like share your audio or something like that.
Let me pause it. Okay. So I think I have to stop sharing in order to get to that share my audio part. So I'm going to stop the screen share for a moment and see if I can find that setting. Is Pamela on? Could she assist?
Hi, yes, I'm on. Sorry, Tammy, just to clarify, this is share audio for Zoom?
I think so. I think it's, I'm not 100% sure, but I know sometimes if you have
invasion of a normally sterile host of that organism. So it can result in an infection in the body site, including the lungs, abdomen, soft tissue, skin tissue, urinary tract, and even result in some of the primary bloodstream. So bacteria can be the pathogens most commonly associated with sepsis, but can also be fungal, viruses, parasites can cause sepsis. So SIRS, or systemic inflammatory response syndrome, this is that inflammation or that inflammatory response that your body does. It's that whole body response. You got SIRS can be diagnosed at the bedside, and it can include 2 of the following signs and symptoms. So you can have either be hypothermic, having your temperature being less than 36 degrees, or hypothermic, being greater than 38 degrees Celsius. you can have a rapid heart rate being greater than 90 beats per minute, or even that respiratory rate being greater than 20. And respiratory rate is actually one of those really defining things. There's like 99% of your septic patients are going to be have tachypnea. So, really defining in, we don't pay attention to respiratory rate as much. We look at the blood pressure, we look at the pulse, but we really don't look at that respiratory rate as much. And then also the white count being greater than 12,000 or less than 4,000, or having those immature neutrophils being immature, so that white count. So sepsis is all of those together. So it's more than just that inflammation, it's more than that infection, but it's that known infection that they have with that SIRS criteria. So you're having that infection along with either the temperature, the white count, the heart rate being up or the respiratory rate being up. So that is sepsis. It's that inflammation, that infection, along with the response that your body's having to that. So now we look at severe sepsis, and we have all of those other things. We have a septic patient, but now we're having an acute organ dysfunction. So we talked about, or somebody had mentioned their organ dysfunction as being the kidney, having the low urine output or having that creatinine go out of whack. Or it can be the cardiovascular system. Their cardiac system is not up to function, or the renal. We talked about the renal already. Respiratory, they're either, not breathing efficiently, they're needing more oxygen in that sense, or hepatic liver functions are getting out of not being normal. Hemostasis, their blood pressures are not what they should be, or they're modeled in that part. Their central nervous system, they're a little bit confused, a little bit agitated. Family says, that's just not their personality. That's just not what they're normally like. And you get that a lot. They're completely alert and oriented, but they're short with you. They don't have that patience with you. And family says, oh my God, they're usually the sweetest person in the world. And so that little bit of that central nervous system is not quite right. Or that expected metabolic acidosis. So you've got that severe sepsis is your infection along with that SIRS criteria, and now you have acute organ dysfunction. And then you ended up getting into septic shock. So now you have all of those things I just mentioned, along with the low blood pressure now. So we have that acute organ dysfunction, the response to the infection or some sort of inflammation, and we have an infection. But now we're having hypotension despite adequate fluid resuscitation. So now this patient is in shock. They are not, blood pressures are low and we can't get them back up. And so in essence, you can see how that can be a very complex disease. All of those things come together to make for our septic patient, and it can be in those categories and where we get into that septic shock part. So we can end up in that continuum as to what's going on. We can end up with that infection. We can end up with the SIRS criteria from the infection. We end up with being sepsis and then severe sepsis, the septic shock, the blood pressure that's not responding to fluids. We end up with multiple organ dysfunctions, and then you end up to death. And this continuum can be very short. It doesn't, it can be a very short time period that this whole thing happens, or it can be a little bit longer. But catching that in that continuum, we can hopefully prevent them from getting to that death part. So you can see how sepsis can be very complex in the definitions and how that works.
I get everybody's favorite, the pathophysiology. Go back to your A&P here. So it's very complicated. They don't know everything. Obviously, the human body is very complicated. We haven't figured it out yet. But I'm going to talk a little bit about what happens that we do know that happens as far as pathophys, and some of the signs and symptoms and clinical presentation that you're going to see, and hopefully it'll kind of trigger some of these things when you're looking at your patients. So in a normal infection, your body recognizes a foreign protein or foreign antigen. And this can be from the cell walls of the bacteria, from the yeast, it can be from the DNA, the RNA of the viruses. And T cells go and they bind with this foreign antigen. And when they bind with them, they release or start the activation of the white blood cells. So you have your macrophages going out, your neutrophils going out. At the same time, they release special proteins called cytokines, and these guys are there for your pro-inflammatory mediators. They send these out and they get the inflammation going. So they also, are the cytokines, as they go to the site of the inflammation, injure the endothelial wall. And the endothelial wall is kind of the barrier, it's the inner lining of your blood vessels, and it's the barrier between your intravascular space and the soft tissues and the sub-Q underneath it. And what happens when they injure it is they start the clotting cascade too at the same time. So a lot of things are going on. You have in homeostasis, your coagulation, your inflammation, your fibrolysis are balanced. And when they're balanced, the infection stays localized. If they're imbalanced, that's when the infection becomes systemic, or what you see in sepsis. It kind of spreads throughout the system. So when you have your inflammation at the site of the infection, you also will, like I said, you'll have your coagulation, but it damages the endothelial tissues. And what you have is you have a capillary leak syndrome. So you have fluid leaking from your intravascular space into the sub-Q or soft tissues underneath. And as it leaks, of course, what happens to your blood volume? Your blood volume decreases. So you have a little bit of hemoconcentration, thickening of the blood, which again helps with the clotting cascade. Your blood is getting a little bit sludgy. At the same time, your endothelium does many things, and when the neutrophils attach to the endothelium, they also release a very potent vasodilator called nitric oxide. So not only do you have leakage from your intravascular system, but you got vasodilation going on. So you can kind of see now how you're setting yourself up for that decreased blood pressure when this is going on down there at the microvasculature. Your coagulation, when you have any damage, the leukocytes adhere to the endothelium and makes it sticky where it normally would not do it. And so you have the coagulation cascade going on. In a sepsis, this is increased. The coagulation and inflammation go together. You can't have inflammation without coagulation. You can't have coagulation without inflammation. And in a normal situation, if it's balanced, what will happen is the coagulation cascade, your fibrin and your thrombin will kind of block off that infection. Your body will destroy the antigen, and by the time the clot has lysed, the infection's been destroyed, so it stays localized. Like I said, in sepsis, though, this doesn't work. It's not working. You have a hyper kind of coagulation and inflammation type state. When you have fibrolysis, anytime you have coagulation, you're going to have breaking down of those clots, and you're going to have D-dimer forming. So when you see your labs, you might see D-dimer in the labs. But in sepsis, for some reason, this isn't normal. For some reason, the fibrolysis is depressed, which again is kind of helping spread the infection. It's just not working right. So at the microvascular, this is kind of what you're going to see, and it depicts the picture of it. You're going to have your increased inflammation, your increased coagulation, and your decreased fibrolysis. So in that microvascular, you're going to have your clotting going on with your inflammation. You're going to have your white blood cells, your macrophages, your neutrophils. You're going to have debris from all the things that are going on. You're going to have so much there that your oxygen and nutrients can't get into the cells, and waste products can't get out of the cells. So, and you end up with hyperperfusion. So oxygen's not getting down there. And as you know, then you'll end up with hypoxia, ischemia. And as it progresses, like Patty said, you're going to end up with organ dysfunction. Your organ's just not going to work quite as well. And if it continues, you're going to end up with organ death. So sepsis really is a disease of the microcirculation. The microcirculation is the first to go and the last to come back. If you can rescue the microcirculation, you will have a successful resuscitation. So the end point is actually, like I said, getting that perfusion down deep into the microcirculation. They've actually measured this. They've measured it not only sublingually, but in the stomach. And this is kind of a telling picture. If you look at this, this is a sublingual depiction of the circulation. On your left, you have your healthy volunteer, and you can see kind of how the circulation looks in that healthy volunteer. On the right, you have a septic patient who has had fluids, has been volume resuscitated, and is also on a pressor. And even though he's got an okay blood pressure, heart rate's okay, you can still see that there's things going on. Sepsis is kind of a severe thing. You can see why we want to really push this golden hour and continue the treatment of them. So time is tissue. Oxygen won't go where the blood doesn't flow. Again, we optimize the macrocirculation to get it down to the microcirculation, and our goal really is to save that mitochondria before it's permanently damaged. If you remember way back to your A&P, if you remember the Krebs cycle, you know, if you have oxygen, your cells can make 36 ATPs for energy for the cells. If you don't have oxygen, you make 2 ATPs. So you really do have a big deficit. And that's really kind of where we're talking about. Time is very important, because how long can you have that deficit before you have permanent death or injury of the mitochondria at the cell? So now what? Sepsis is kind of a, as we go through some of the body organs, you're going to see it's kind of a vicious cycle. It spreads. If you can't stop the cycle, it's going to continue to spread and get worse and worse and worse from the inflammation and the coagulation that you're seeing. So Patty had said that you can have acute organ dysfunction, and you can have them in any organ of the body. And we're just going to kind of go over some of the organs here and kind of look at some of the symptoms and some of the lab values that you're going to be seeing. So looking at your CNS, again, like you think about that, it's going to attack the blood-brain barrier, and it's going to kind of make that hypoperfusion. You're going to have your macrophages, your neutrophils, your coagulation, your inflammation. And what happens is that oxygen can't get into the brain. And you know, your brain is very, very sensitive to hypoxia. So one of the first things you're going to see in a septic patient is maybe some altered CMS. So if you look, mental changes you maybe see, but just might be inattention, disorganized thinking, like Patty said, foggy. When a family member comes in and says, Dad's just not acting normal, Mom's just not acting normal, they're usually sharp as a tack, and today they're not on. It's just like something's missing up there. So your caregivers and your family can be very important in finding out what is normal or what is baseline for this patient and what is not normal and baseline. You know, we could just write that off, but that's kind of a key. If you're hearing that, you got to think, what's going on underneath here? If you look at the respiratory, Patty mentioned respiratory is one of your earliest signs of sepsis. They increase that respiratory rate. We don't look at respiratory rate the way we look at blood pressure and heart rate. I mean, respiratory rate's just kind of put to the side a little bit. If they come in with a 24 respiratory rate and their SATs are 90%, do you think they're doing okay? A lot of times, they're doing okay, right? But then pretty soon their SATs are going to fall. They're going to go to 88, 89%. And what are we going to do as healthcare providers? We're going to help them. We're going to give them some oxygen to bring those SATs back up above 90%. Now they're doing okay, right? Not necessarily. Their compensation is failing. They are failing. Earlier they were able to compensate, and now it's failing. Pretty soon their SATs are going to drop again, and you're going to give them oxygen, and you're going to give them oxygen, and those SATs aren't going to come back up. So if someone is got oxygen on them and you're not bringing their SATs up, that should be a red flag for you. So you will see decreased oxygen saturations. You will see those kind of things from hypoxia. They're going to be restless, irritable, anxious, kind of air hunger, shortness of breath kind of things as it progresses. Hepatically, the liver is the first line of defense against many things. It clears infectious waste. It clears your metabolic waste from cells. It clears your medications. So if you see things like you're giving medications and they're lasting a long time, you know, in a septic patient too, that might be a thing. You gotta watch what you give. As it progresses, it doesn't clear those metabolic wastes. The bacteria, the toxins, the debris, it's going to let it all spill back into your circulatory system. And what's going to happen? It's going to keep that vicious cycle going. It's going to keep spreading that infection and that disease. Metabolically, when your cells go down from aerobic metabolism to anaerobic metabolism, you're going to start that lactic acid production. So your lactate levels are going to rise. After it reaches a certain point, you're going to end up in metabolic acidosis. So again, looking at your lactate levels, maybe doing an ABGs, kind of see what those look like. Lactic is very important in sepsis, and I'm sure you've heard this not only earlier, but I'm sure you'll hear it again. We look at lactate levels, and the half-life of lactic is about 20 minutes. So when you do a lactate level on a patient and you recheck it in 3 hours, in 4 hours, in 5 hours, you are not measuring the same lactate. It's already cleared. This is telling you 3 hours later that there's new lactate. We're still in anaerobic metabolism, and that something is still going on deep down at the microcirculation. Your lactate can be raised by other reasons. You know, Patty talked a little bit in the beginning. Trauma will raise your lactate. Seizures will raise your lactate. Medications will raise your lactate. Metformin can raise your lactate. Hyperthermia can raise your lactate. DKA can raise your lactate. There are things that do raise your lactate, but your lactate levels should not stay prolongedly raised like you will see in sepsis if you don't treat it or don't start fixing it. So that can kind of give you a key there too. At the 6 hour window, they really want that lactate checks because studies have shown that at 6 hours, if you have not decreased your lactate by anything, you have a 50% mortality. So that kind of tells you too, how am I doing with this patient? Are we doing the right things? Are we hitting him hard enough, treating him aggressively enough? If your lactate at that 6 hour point drops by 10%, you have decreased that patient's mortality by 11%. So again, looking at lactate kind of tells you how are we doing and how are we giving this care to this patient for these better outcomes. Hepatically, sepsis is a disease where you have clotting and you have fibrolysis too. So what happens is you've got the clotting, your body to kind of, anytime you have clotting, your body's gonna try to balance that. So you're gonna start having breakdown of clots where you're producing that D-dimer. You're going to start using up your clotting factors. So you're going to see your platelets fall. And as you see your platelets fall, of course, the other things are going to go up. Your PT, PTT, INR are going to rise too. So as you progress in the system, you're going to see changes in those things. Cardiovascular wise, one of the first things you'll see is tachycardia. What happens, like we talked about with that capillary leak syndrome, you're going to have vasodilation, decreased blood volume. So what's your body do? It's going to release catecholamines. Those catecholamines are going to try to increase that cardiac output to the site. So what they're going to do is cause vasoconstriction and increased heart rate. And that's going to be one of the things you're going to see to increase that cardiac output. But at the same time, those inflammatory molecules that are going around also have a depressant effect on your cardiac output. So it kind of is working against it too in that way. Again, that capillary leak syndrome will continue if you don't stop the cycle. You'll see that hypotension. Renally, you can talked about renal failure, acute renal failure. Could be temporary, could not be temporary. You'll see that oliguria, anuria, increased BUN, increased creatinine, gastrointestinally. Again, it attacks the mucosa of the gut. You can have things like abdominal pain, nausea, vomiting, intolerance to tube feeding if it's a patient in the hospital. As it progresses, you can have GI bleed and ulcers and things like that. And of course, we have a lot of bacteria in the gut, and that bacteria in the gut, as it progresses long enough, of course, so what's it going to do? It's going to spill that bacteria back into the circulation. Again, increasing the problem. For every organ involved, you increase your chance of mortality. And if you look at the graph, one organ, 20%, it doubles your mortality with each organ that you add that you're having organ failure with. So again, you want to get this early goal-directed therapy to treat these patients early. So we think 100, 100, 100. Is the patient's temperature above 100? Is their heart rate above 100? Is their blood pressure below 100? And are they just not feeling right? Little Mr. Weber that was here earlier. The first time I met him, one of the first things he said is, I told my wife I need to go to the hospital. And she said, well, I'll take you. And he said, no, I think you better call an ambulance. I'm just not feeling right. Kind of funny he used that exact verbiage. I'm just not feeling right. So they know themselves something's just not right sometimes. And that's a key. So if you meet that 100 criteria, again, like what Patty said earlier, think about that Sears criteria. Do I have a known infection or potential infection? Do I meet that SIRS criteria? Is my blood pressure below 100? Is my heart rate above 90? Is my respiratory rate above 20? Am I hypo or hypothermic? Is my temperature above 100.4 or below 96.8. And thinking, you know, if you've got your lab, the other Sears criteria you can meet is my white blood cell count high or low? Is it above 12,000? Is it below 12,000? And what about my immature neutrophils? Are they greater than 10%? Look and think about that Sears criteria. You can do the quick 100 in your brain, but again, look more formally at that Sears criteria when you're trying to identify these patients to get that early identification for sepsis and then get that early goal-directed therapy going.
Thank you for sharing your screen, Pamela. Now, I know that was a very detailed presentation, but the point of it is just so that you can understand what's going on. If you see someone at bedside who's got an who has a known or a suspected infection and has that elevated heart rate, an elevated respiratory rate, the pulse is rapid, then you know there was something going on inside the system that's triggering that, that's causing that to happen. And what it is, it's the body's trying to fight off the infection in such a way that it's really destroying some of the healthy tissues and the healthy organs at the same time. So what I'd like to do now is to put you into your small group sessions, just to take a look at a case study of a resident, and to talk amongst yourselves in your small groups about the discussion questions that I've given you as part of that exercise. And then we're going to come back and talk about that as a group. And what I'm going to ask you to do while you're in your small group sessions is to identify someone who can report back for your small group and kind of share with the larger group, share with us what your thoughts were about this scenario that's been painted of a resident who we think is showing signs of sepsis, and also to kind of talk about what you think you already have available in terms of tools that could help address that early sepsis signs in this individual, and then what you might recommend if their symptoms don't turn around. So if the blood pressure doesn't come up, if the temperature doesn't go down, if the respiratory rate doesn't go down, what do you think should be the next steps, and how would that happen typically in your institution if a patient like this presented? So I know someone is going to do the random group selection to place you into your breakout groups. And what I'm going to do is put the exercise into the chat so that you'll have access to it while you're in your small group sessions. Kimmy?
And do we want to do 15 minutes for that, just so it's not too?
Yes. 15
minutes for the breakout? Okay, I'll put the case study in the chat now.
Okay, thanks so much. It is 2 o'clock. So if you could take 15 minutes in your small group sessions to walk through the questions, and then we'll come back to the larger group and talk it through.
All right, I am going to launch the breakout rooms now, and we'll be sending updates on how much time you have left. So happy chatting.
Question 1 for the small group exercise was, what concerns would you have as a nursing supervisor about Deborah? Can I hear from someone? What was the discussion like in your group about that?
We can go first. Our group consists of Pat, Martha, Laura, Jennifer, Esther, Edith, and myself. The first response is we try to do our assessment and put the resident in bed, start the resident on oxygen, monitor the vital signs, review the medications, and recommend hydration to the MD and some blood work. That's where we stop at question 1.
Okay. Did any of the other groups recommend something different or additional?
Yeah, our group, we, a couple of us, I can't recall names, but we came up with a conclusion that we recommend, like what it says. First thing, you want to initiate oxygen therapy, and also elevate the patient's head in bed. So we want to propose you do some requests for some blood work, possible blood work, stats chest X-ray. It depends on the kind of doctor. Some people can give you, after collection of urine, you give one-time dose of like Rocephin after you collect the urine to see how the patient respond. So based on all those interventions, then if there's no improvement, then probably thinking about sending to the ED.
Okay.
So I'm also in the same group with Tao, and one of the key important thing we talked about was review of the patient's most. Because we are in a SNF, some of them, their most will say no IVs, or maybe IVs for a short period, or do not transfer to the hospital. So it was key for us to review the patient's most, even though we do all the same assessment, like they both have mentioned, but we still review the most to see if there's any aggressive treatment required for this patient or not.
In our group, we also talk about, monitoring the patient's blood sugar, even if she's not a diabetic, we don't know. So we can check the blood sugar and also assess for pain. Because in this situation, the patient may be in pain and that should be addressed.
And we also indicated that we would do the assessment and report our clinical findings immediately to the provider and get the orders for labs or whatever has to be done, especially IV fluids and what have you, labs also.
So let me ask this question. Would there be any barriers to doing what's been suggested? Can stat labs be easily obtained? Is there someone available and the equipment available to be able to do the IV fluid resuscitation easily?
Mm-hmm. Yeah,
in our group,
one at a time.
Go ahead, Sadia.
So in our group, we did discuss the different options, and if the possibility wasn't there to have those labs returned in time, then we will, make sure we talk to the doctor that the patient needed to be sent out, because it's based on our assessment. Since as nurses, we're in-house, usually calling the doctor who's not on site to report. So we'll have to communicate the severity of what's going on with the patient's condition and let that doctor make the judgment call based on our assessment findings and report to the doctor, because not always that we can, we have the luxury of time. We discussed that time is muscle, and this is not something that can wait, looking at how she was decompensating.
Yeah, our group said a similar thing. Depending on what shift we're talking about, if it's in the middle of the night, being able to get all those things done, not such a high percentage of success. So, when there are nurse practitioners around and physicians during the day or during the, the shifts when they're more available, that makes a difference in outcomes.
So, I mean, where I work, we pretty much function the same way all shifts. It just depends on your contracts with your lab vendors and the X-ray company and how they've been responding to you during starts. So usually those kind of information help you to predict if it's something you can actually take care of or the person needs to be sent out.
But most of the time start is always 4 hours.
4 hours.
Yes. That's the time. I've never seen it start less than that.
Yeah, but what we're trying to talk about is if even the start is 4 hours, but based on your current intervention, if you apply supplementary oxygen, you gave fluid hydration, maybe the doctor order, maybe Rocephin, you administer that. That will also help you with your judgments if you need to keep the person, because once the temperature start going down, the oxygen is going back up, the heart rate is going down, then there's no really need to send the patient to the hospital. Then you can always eat the 4 hours window.
The other thing that came up in our group is using a broad spectrum antibiotics, because the suspicion of sepsis is already there. So before we even get the labs back, if the physician agree with the broad spectrum, we can go ahead and get that going. And I think it might buy us some time.
Yeah, so the key is accurate assessment of the situation and communicate everything to the physician to enable the physician who is not on site at that time make the proper decision, because everything there is so obvious. So if you communicate this, the physician will be able to guide you or give you the right orders to be able to sustain the situation until the lab, because even you already know that the BUN is going and creatinine is going to be out of whack. So even though the lab is going to confirm it, you know already. So by communicating everything correctly to the physician will help make a good decision as to how to handle the situation.
So let me ask, is there ever a time lag in terms of reaching the physician on call to be able to get these orders?
Yeah, we technically have a protocol. When you reach out to the physician on call and he or she is not responding, then we have the medical director with a backup.
Yeah.
We don't have that issue here.
And we also talk about the way of communicating with the physician, because non-urgent situations will just use a text message, secure message through our EMR. But situations like this is going to be a phone call. And even though we have our physicians on site, they are employed by the facility, we always have one on call during odd hours. So they know if we call them, they will respond. Because once we pick up the phone, they know this is a situation that they need to act on. So they will respond. And like my colleague said, if you wait for about 15 to 30 minutes, no response, you call the physician. You call the medical director. Sorry.
And then we have the lab that visit twice a day on campus. You come in the morning, you come in the afternoon.
I think the most current thing is to be sure that we get the physician as soon as possible and start the fluid resuscitation, put the oxygen on. Look at all the vital signs. She seems like she's decompensating and going straight to sepsis. So we really need to get a move on it. And if the labs cannot be waited, and I think if the patient is a full code and needs to be sent out, then the patients need to be sent out because of the fact of her declining rapidly. And with her tachycardia, vital signs like that, it seems like she's going to sepsis.
In my facility, some of the providers who work here, they work in Nexus Montgomery, and so they have access, and sometimes they are the ones on call, so they already know most of these patients that we are talking about, right?
I guess too, guys, the other one thing I'm reading as we're all talking about all the stuff we're going to do, which makes sense and is right. You wonder though, for the past 2 days, as you read this, past 2 days, she's had limited oral intake, right? And she's had nausea and vomiting and decreased appetite. You would hope that today you're coming on board, that this isn't the first time everybody's heard about that or is trying to take care of that. It looks like that's something that hopefully was put on the stop and watch, 2 days ago, or at least a day ago, right? So we probably could have hopped on this a little sooner, or it could have been taken care of or looked at a little bit more, because you wonder why she had nausea, vomiting, and wasn't eating. So again, you're coming into a funny situation. The full code, which we all know, we want to ask her too, maybe does she want to have us call one of her family members? If she's alert and orientated, she may not want you to do that. However, I know we would as a group, you want to call somebody, let them know that she's had a change so nobody's in shock if something does happen, right? So I was just reading that while we were all talking about all the stuff we normally do. That's great.
Yeah, I mean, I agree with you, because technically if someone start throwing up breakfast, lunch, and dinner, then you already know there's a problem before it gets to 2 days. You know?
Exactly.
Yeah, so even though stop and watch is good for staff to document that, we prefer to report it into the charge nurse in real time. Because GNAs with the stop and watch, even though they saw it, if they don't report it right there, their documentation is after they have finished doing whatever they are doing, and that may be too late. So we prefer for them to stop and report. Stop, watch, and report immediately before documentation.
That's why that's such a good tool. We're constantly in servicing that tool.
Okay. All right. Any final comments before we go back to the PowerPoint? Okay. All right. I'm going to share my screen. And we'll have a chance to go through any questions that folks may have about the remaining material at the end. Can you see my screen?
Yeah. We forgot, we did not discuss about family notification. Family notification, and also for the resident to know if the resident is alert and oriented, to know what is going on with him or her, and to know what you are thinking and what the doctor has asked you to do for her.
So that's an important component. At what point would that typically happen?
Sorry, doctor, I thought we were only answering question 1. I mean, I thought you said we should give response to question 1. We had 4 questions.
Yeah.
Yes, I thought we had gone through them.
Everything.
Oh.
Yeah, okay.
We kind of jumped around, but it seemed that we really covered the bases in terms of all of the questions.
I think for this particular patient, it would be notifying the family after we speak with the physician and we have a plan of action in place. I don't think that the patient would be an adequate person to speak to, because in the summary, it said that the person was having altered mental status.
So does everyone agree that family members need to be read into the picture so that they're not surprised if it comes to the point where a resident might need to be transferred?
Yeah, well, it's about definitely sometimes in some scenarios, family comes last, because at that point, sometimes when you don't even have the, your most form comes first, then you go with the physician. I mean, sometimes reaching the family that have to send someone out, after the most form has been done, because the most form guide us on what to do. So if it's a case whereby it's getting too late, I'll put the family last. I'll send the patient first after the doctor's order, and I'll update them about what's going on.
Which is
I mean, obviously, I do agree with that, but my main thing is, even if she was alert and with it, I feel somebody needs to be informed, because the thing is always, it comes back that nobody has said anything to me. Nobody told me this was going on when things go south. So I feel that somebody, I'm just letting you know, FYI, this is going on, even though the person can make their own decisions or whatever. And in this case, just as Jennifer said, she already has altered mental status. So we need to update somebody.
I think I agree to that, because our family members at last minute can change the most form. So, I mean, they need to know right from the beginning. For them to be aware, yes.
They need to know, and if you can tell them what's happening, and then you can let them know, we'll call you right back and let you know what's going on, and if your patient's going to be transferred out. So you communicate with them always. I think you should call them.
Yeah, but you have to identify who to communicate with, because there are so many of them listed, and then you cannot be wasting time going from one person to the other. You have to identify that. If you fail to contact the first person, then you go to the second one, but then document. Yeah.
Then it has to be someone who have the rights to change the most form.
Yeah.
But I also think that it's better to allow them at the beginning. Sometimes they want to change their mind.
Right.
Even if it says do not transfer, some of them might say, okay, in this situation, I want my dad or my mom transferred.
Yeah.
And then you'll be communicating that to the doctor.
But if this most form was done by the resident when they're alert and with it, should it be altered by somebody else? I don't think so.
In situations like this, you will have to get another nurse to assist. It's not going to be just you. So you will be able to contact the family, have the other nurse work on getting the family to let the family know that I have a situation here. My colleague is dealing with the doctor. We will update you. So you can do both at the same time, since you always have a nurse or somebody available to assist you.
What would change? What would change if this patient had a DNR? How would you proceed differently?
I think you still have to let them know what's happening. They still need to know.
Yeah, and it depends
But,
because
yeah.
sometimes you have someone who's a do not resuscitate.
Yeah.
However, they choose the
Transfer to the
option to
hospital.
transfer to the hospital. Or they have an option that you can maybe do not resuscitate, but may intubate and may use like oxygen measures.
And the family still need to be notified, at least.
All right.
Yeah.
Okay. All right. I'm going to go back to the presentation now, and you know, we'll still have some time at the end for questions and discussion. Can you see the presentation?
Yes, doctor.
Okay, great. Let's see if I can advance. Okay, here we go. Okay, just a little bit of data. Sepsis is a big problem in the US. And for patients who end up in hospital, more than 30% of those who have a mortality in the hospital, sepsis is the underlying reason. So 30 to 50% of hospitalizations that end in death are the result of sepsis. So this is a big problem in the US. In Maryland, it's among the top 10 most common potentially preventable complications and one of the leading causes of mortality and readmission. It's the 9th leading cause of death in the state. Okay, and then we have some local data. Again, about 9% of hospital admissions were for sepsis. They use the term septicemia in the data, but it's sepsis. And it's about 11% of the reason for readmissions, which is a big concern, especially on the acute care side. And then in the county, about 12% of initial hospital admissions were for sepsis, and about 16% of the readmissions were for sepsis. So after a sepsis occurrence, again, a really high rate of rehospitalization, a pretty significant rate of mortality, about 16%. And again, pneumonia is the most common site of the initial infection that grows out of control and results in sepsis. And these are some of the risk factors. You know, again, age, the length of a hospitalization, and then the presence of an indwelling catheter, because it's a way for infection to get inside the body. So I know that, you know, in your roles in skilled nursing, the importance of infection prevention has probably been, you know, it's probably not something that you're hearing for the first time. CDC has this training course that they provide that can train infection preventionists. You probably have infection preventionists working with you to kind of generally help to improve practices and policies and performance related to infection prevention. So, you know, I know I'm preaching to the choir here when I say that really the interrupting the path to serious infection really starts with infection prevention in general. And this course is free and available at this website. So vaccination is a critical thing, because if pneumonia is the most common infection site, then making sure that people are up to date on their pneumonia vaccinations would be pretty important in terms of trying to prevent pneumonia infections. But really all infections, the kinds of things that you're doing to keep infection rates low in your institutions, all of those things are part of the process of preventing sepsis. Personal protective equipment, making sure it's properly used, that people have been trained, and that if they're doing something that's exposing them to bodily fluids, that they have the proper equipment available, it's easy to access, and they know how to use it. So I am going to skip this video because I want us to have some time for discussion at the end. And I don't want us to have to switch hosts again. So these are the common signs. So in altered mental status, so confusion, just, someone who exhibits a sudden change in their mental status. And sometimes sepsis starts with some kind of an accident or a fall that then leads to some kind of an infection, and then, a cascade of events start. But again, you're looking at people who are suddenly feeling unwell. They're off their baseline. And then the vital signs are showing you that something is going on. And if they have a suspected infection, if you can identify a site, they're showing respiratory symptoms, or maybe they have a wound that's showing signs that it may be infected, then the combination of the altered vital signs, the change in mental status, and an infection site that you can identify, that's the combination that you really want to be watching for. Now, the problem, of course, is that many folks who you're working with may already have some kind of baseline cognitive deficit. And so it can be really tricky trying to point out a change in mental status in someone who's already a little bit altered, and that's their baseline. But that's why it's important really to, that the people who are most familiar with that resident are trained to be able to alert you that, yes, so-and-so is normally, perhaps, not the sharpest knife in the drawer, but today they seem different. And we need to pay attention to that. And when they're monitoring the vital signs, we've noticed a change as well. So it's that combination. But it's not always sepsis. I mean, there's things that can cause people to show signs that really are not sepsis. So the increased respiratory rate could be some kind of an ongoing respiratory problem like asthma or COPD. And then a lot of people are on medications that can change their blood pressure, okay, or change their heart rate. And so, you have to know who you're dealing with, what their history is, what medications they're on, before you jump to the conclusion that this is sepsis. But at the same time, you want to have a high index of suspicion. Because, if we miss it and we don't recognize it early, then the consequences can be really quite severe. I'm sorry, I'm going backwards instead of forwards. Okay, so this is a tool, and really almost all of the tools that that we've reviewed and that we're going to be making available to you in your training manual really do start with stop and watch. And then they go on to combine some of the other information that you're getting about the resident, like the monitoring of the vital signs, and if there's some kind of an infection, like the information to put into kind of a package. So a change in their condition combined with a known infection, combined with change in vital signs. Almost all of these pathways really rely on that combination of factors. And what the tool that you're using, in my view, is not as important as acting on the information that the tool brings to you. So really reinforcing the ability of the bedside caregiver to be listened to when they notice that change. So is there a clear protocol that they can follow for alerting, and for bumping that information up the clinical chain so that the appropriate information can be acted upon? Do they feel comfortable doing that? Do they understand the signs well? Is there a clear protocol for reporting it? So those are questions that you need to be thinking about. I can't answer those questions, but to the extent that people don't feel that they are well-trained and don't feel comfortable reporting, that means you're not going to hear about what you need to hear about soon enough. So stop and watch is kind of the basis. And anybody can be trained in stop and watch. It does not have to be clinical personnel, and it ought to be anyone who spends time with residents. So that would include, folks who are working on the rehabilitation side, people who are serving food, and it also includes family members and caregivers. So I want you to begin thinking about ways to ensure that everyone who spends time with residents is familiar with one of these very simple to administer tools that help you to spot the signs and symptoms. So it doesn't have to be the more complicated one that clinical staff use. It really can be something very simple like stop and watch at the onset. And during the second training day, we're going to do a much deeper dive into these tools. But today I just want to kind of, discuss them in broad brush. So all of the tools kind of culminate with this SBAR report, the situation, background, assessment, recommendation, because when you get to the point where you have something to report and to recommend, this is the format that you use to alert the physician on call or potentially your medical director, if you can't reach the physician on call, that there's an issue that we need to act on. And so the information has to be put into this format. And there are, of course, lots of tools to help you put the information into this format. But a lot of it does start with altered mental status. It's really one of the earliest signs. And there are lots of different tools also that can be used at the bedside to gauge whether there is a sudden change in mental status. This is just one of them. So I think there are really two big buckets, as I mentioned earlier in the presentation. So there are people who are fine and then who may develop an infection that becomes full blown and that can lead that resident down the path to sepsis. And that happens for the first time in the skilled nursing facility. But there's another group of people, as I said before, who are at higher risk. And those are the ones who are coming to you after a sepsis incident, after a sepsis, after they've been treated for sepsis in an acute care setting, and they're coming to you for step down care. So that second group is at much higher risk, really. And so, that second group, we need to pay attention to when they arrive, so that people can be alerted that they're at higher risk. And then if an infection develops in that group, you're monitoring it a bit more closely than you might for someone who has never had sepsis. So one of the barriers, this is going to be very important for for the physicians and medical directors, because they're going to be worried about if they prescribe antibiotics for someone in the hopes of preventing an infection from progressing, are they contributing to some of these lingering problems with infections that are linked to antibiotic overuse? And these are the kind of the top three: the MRSAs, the Clostridium difficile, and resistant organisms that are resistant because antibiotics have been used frequently in the population. So I'm getting a question in chat. Let me just take a look at that. can't get to chat from here, but if there's a question, if someone could just let me know what it is and I'll try to respond. So again, in the nursing home setting, the important thing is early identification. It's training of people who interact with residents, all of the people. And it's training of family members and caregivers, because they can be very useful in alerting you to a change in the condition of their loved one, if they're encouraged to do so. Now, some facilities have instituted programs and protocols so that they really try to be aggressive in treating in the nursing home or the long-term care setting. This may not be for every institution. You know, you have to decide what your policy is going to be, and when you feel you're not comfortable continuing to have the resident remain in the nursing home facility, and when you might need to send them out. But if you decide that you want to not only fluid resuscitate, but also potentially to treat, then you need to have some things on hand in order to make that happen. So that, again, access to stat labs. You may need some standing orders so that you don't have to wait to get that approval from the physician on call to be able to get things moving and to start things. So that would mean some standing order sets would have to be on hand, so that, you know, your nurse practitioner is empowered to be able to begin treatment, and then to inform the physician on call. You know, we had a situation that was emergent. We began treatment. We're letting you know about that. How would you like to proceed from this point forward? So these are some things to be thinking about. But regardless of whether your goal and your priority is early recognition, or whether your goal and priority is early recognition and let's do everything that we can here so that we don't have to send the patient out, you still are going to need to be able to have that system in place so that the information flows quickly to you, so that you can monitor more frequently if someone is showing signs of sepsis, and so that you have a way of recording what happens in the event that you might get to the point where you need to send them to an acute care facility, that you have a very clear timeline and record of everything that has happened that can travel with them to the emergency room. These are some examples of things that might need to be on hand if you're going to have that sepsis kits available, so that you can do the blood cultures, a pulse oximeter, all the things you need to be able to fluid resuscitate. And, you know, again, in the acute care setting, they're going to be measuring lactate levels and administering vasopressors. You know, that's what's going to happen in the ED. And I'm going backwards again, so sorry. But, you know, some centers, some nursing home facilities have opted to try to implement these things that are included in the 3R bundle in their facility. So broad spectrum antibiotics, doing the blood cultures to really try to identify what's the source of infection, and then administering additional criteria. I'm gonna move forward through this and we'll cover that the next time. So really the goal is to, if sepsis is happening, to get effective treatment implemented early. And this chart, I think, really illustrates that. So the gray bars are time to administration of antibiotics, and the black bars are survival rates. So basically, the longer it takes for the antibiotics to begin, the shorter the survival time of the person who's receiving them. So this is a pretty telling graphic. So I'm going to stop there and stop sharing my screen, and I want to take questions.
So we don't have any questions in the chat at the moment. If you have any questions, you can put them in the chat, or if you want to unmute to ask your questions, I think that will be fine as well.
Janet, this is Jackie. What will we be covering in the next class? You did quite a bit in this one. Thank you.
Yeah, so in the next class, we've identified a couple of, kind of programs that have been implemented in nursing homes where they've really tried to implement the 3-hour bundle and have, and where they've implemented kind of across the board training programs for caregivers, for certified nursing assistants, and also for more highly trained clinical staff. And so I'm going to kind of talk about how they did it, the elements of the programs and the tools that they use to implement them, and then also to talk about the data, because they measured kind of changes and outcomes prior to implementation of that and then after. So that'll be part of what we'll cover. We're also going to do a little bit of a deeper dive into some of the concerns about antibiotic over administration. We have a couple of first-person accounts from people who have experienced a sepsis infection. And then the last part of it really focuses on quality improvement and performance improvement, how that could be folded in to infection prevention, and who might be involved in creating that kind of a program if you wanted to implement that at your facility. So what kind of information would you need about your current rates of sepsis, how might you go about collecting that information, and then how might you set some goals in terms of training, improving early recognition, and really systematizing the protocols for how you respond to people who are suspected of having sepsis. And then the last thing is the use of the electronic health record. Many of the places who have implemented these quality improvement initiatives have embedded alerts into their electronic health record. They've tried to make it really as painless for people as possible. And in some cases, the vital signs will auto-populate and an alert will go to someone on duty that, these criteria for sepsis have been met and this patient needs to be evaluated for sepsis.
Thank you.
Any other questions? We are about like right at time. So any other questions? Okay, if no,
I want to thank everyone. And I'd also want to encourage you between now and next week to think about anything that my colleague Michelle and I, who I forgot to introduce at the beginning, my apologies, Michelle, but anything that Michelle and I have not included that you think would be useful, especially as we put together the trainer manual for you. We want to make sure that we're meeting your needs and that we're including information that you think would be helpful for you and your colleagues in your facilities.
so I want to say thank you to everyone for taking the time to attend this training. Like we said at the beginning, it's a 2-part training. So we'll be having the second one the same time next week, Wednesday, the 24th. Thank you all for your patience when we had technical difficulties. Thank you for the discussion part. It was a very good discussion. And we will plan to do this as well next week. Like Dr. Phoenix said, if there is something particular that you guys are noticing at your SNF that you would like us to discuss in the next training, please feel free to email me. I believe I sent out an email this morning and on Monday, so you can just reply to that same email address with any questions or comments. If nothing else, I would like to say once again, thank you to everyone and enjoy the rest of your day.
Thank you.
Thank you.
Thank
See
you.
you next week.
Okay, thank you.
you.